Now we will start advances in hepatobiliary imaging. Moderators are Professor Jong-Min Lee, Professor Satoshi Kobayashi. Moderators, please start.
Good afternoon, ladies and gentlemen. This session is Advances in Hepatobiliary Imaging. Moderator is myself, Satoshi Kobayashi, from Canada, Japan, and Dr. Jong-Min Lee from Seoul, Korea. I'd like to start the first speaker. The first speaker is Dr. Keitaro Software from Japan. The title is Applications of Artificial Intelligence for Hepatobiliary MR Imaging. Please start your lecture.
So thank you so much for your kind introduction, Professor Satoshi Kobayashi. So good afternoon, everyone. I'm Keitaro Software from Kobe University Graduate School of Medicine, Department of Radiology. So I've been very honored to be invited and have a chance to talk at the 33rd annual meeting of the Asian Pacific Association for the Study of the Liver. So today I'd like to talk about the application of the artificial intelligence for hepatobiliary MR imaging. So firstly, the deep learning reconstruction algorithm has been developed and implemented into the clinical MR imaging that are trained to improve image quality. So this is a hepatobiliary MR imaging with several sequences reconstructed by the conventional reconstruction algorithm. And right side is images with deep learning reconstruction algorithms. You can see the images are substantially improved after the implementation of the deep learning reconstruction algorithm. So today I'd like to show about several clinical MR images with deep learning reconstruction. So firstly, I'd like to briefly explain the image reconstruction of the MR images. So upper row is in the conventional reconstruction. For the conventional reconstruction, the edge of the case-based raw data is filtered to reduce the truncation, and Fourier transform is applied for the MR imaging to create the MR imaging. And the resultant image is further processed for the image filtered to reduce the image noise. And the final conventional image is transferred to the hospital. So this algorithm, conventional reconstruction algorithm, has the advantage of the easily reduce some of the truncation and high frequency image noise, while the significant disadvantage has occurred for the increased reduced spatial resolution. On the other hand, deep learning reconstruction applies a convolutional neural network directly to the case-based data and create the MR imaging. So this algorithm has several advantages over conventional reconstruction algorithm, with dramatically reduce the truncation artifact and high frequency image noise while maintaining the spatial resolution. So I will show some of the clinical case with liver MRI. So this is a T1 opposed phase images obtained from the patient with cirrhosis. So before applying the deep learning reconstruction algorithms, some of the truncation artifact is prominently observed in the periphery of the liver. While after the deep learning reconstruction algorithm is applied, truncation artifact dramatically reduced and seemed to be disappeared. So this is a heavily weighted what suppressed images. So after applying the deep learning reconstruction, intrahepatic bile duct is clearly depicted with increasing signal-to-noise ratio and maybe increased image sharpness. This is the same patient of the T2 weighted images. This image also improves the image quality by increasing signal-to-noise ratio. So this is our main advantage of the deep learning reconstruction algorithm for MRI. So DLR, deep learning reconstruction highly matches for sequence with relatively higher contrast resolution images. Therefore, the T2 weighted images are ideal sequence for the application of deep learning reconstruction. So this is our study of obtains the three types of the T2 weighted images. This is a conventional fast spin echo T2 weighted image and a 6-slice single shot T2 weighted image and a thin slice single shot T2 weighted images. So before applying the deep learning reconstruction, the substantial image noise has prominently observed, especially on the single-shot T2 weighted images. On the other hand, after applying the deep learning reconstruction, these T2 weighted sequences have the higher image quality by reducing the image noise, especially on the single-shot fast spin echo image. So another advantage for the single-shot T2 sequence has the resistance to motion. So this is the different two cases of the T2 weighted images. On the fast spin echo T2 weighted images, significant substantial motion artifact has occurred due to the patient motion. On the other hand, single-shot T2 weighted image has a less motion artifact and clearly depicted the intrahepatic duct and portal vein. So deep learning reconstruction has been also available for diffusion weighted images. So until now, respiratory single-shot diffusion weighted image or multi-shot diffusion sequence has been applied for the diffusion weighted images of the abdomen. However, this sequence required much longer acquisition time to keep the signal-to-noise ratio. Threshold single-shot diffusion weighted image can be the option for the diffusion weighted sequence because this sequence has the advantage of the less acquisition time compared with the other sequences. However, significantly substantially lower SNR deteriorate image quality before applying deep learning reconstruction. However, the deep learning reconstruction enables to choose three types of diffusion weighted sequence, including threshold single-shot diffusion weighted MRI. So this is the volunteer images for the three types of diffusion weighted sequence. Conventional respiratory triggered single-shot diffusion with deep learning reconstruction, respiratory triggered multi-shot diffusion weighted image without deep learning reconstruction because the deep learning reconstruction cannot be commercially available at this time for the multi-shot diffusion. And this is a threshold single-shot diffusion with DLR acquired on the only 20-second threshold. So SNR of the liver is the highest in the respiratory triggered single-shot diffusion with DLR. However, the threshold single-shot diffusion with DLR has a sufficient image quality. So we can now select three types of diffusion weighted sequences according to the patient condition and the throughput of the MR examinations. So the threshold MRCP is another ideal sequence for the after applying deep learning reconstruction, where image quality can be significantly improved. So this is a paper comparing the three types of the MRCP sequences. Respiratory triggered MRCP without DLR, breath hold MRCP without DLR, and breath hold MRCP with DLR. So in this figure, significant blurring occurred in the respiratory triggered MRCP without DLR because of the unstable patient respiration. On the other hand, breath hold MRCP with DLR achieves excellent image quality by reducing the image noise compared with the breath hold MRCP without DLR. So breath hold MRCP required a much shorter acquisition time compared with the respiratory triggered MRCP. And in this study, regarding the SNR, contrast ratio and CNR has a higher image quality in the breath hold MRCP with deep learning reconstruction. So this is the MRCP sequences obtained at our institution. Upper row is images with respiratory triggered MRCP. Lower row is breath hold MRCP, obtained at 20 seconds. So when successfully acquired, respiratory triggered MRCP is good for the image quality compared with the breath hold MRCP. However, the breath hold MRCP has a sufficient image quality as an alternative to respiratory triggered MRCP when the patient condition is poor with unstable respiration. So as mentioned before, deep learning reconstruction has substantially improved image quality by reducing image noise while maintaining the acquisition time. And more recently, deep learning super resolution has been implemented for the clinical MRI to upscale for the upscaling image resolution from conventional image. So in this deep learning super resolution algorithms, two or three times their filling interpolation has been applied on the denoised low resolution image. And then the Fourier transformation has performed to obtain the GIP applied high resolution image. However, this image contains a significant substantial blur and ringing to reduce the image quality. But by applying the convolutional neural network for this image, deep learning-based high-resolution image can be obtained. So this is commercially available deep learning super resolution images. It's applied only for the teeth-weighted images. So in the left side, the conventional reconstruction has performed for the image, but this contains a substantial image noise, deteriorating the image quality. So deep learning reconstruction algorithm has improved image quality by denoising. Moreover, deep learning super resolution seems to provide a fine image quality due to the higher spatial resolution. So diffusion-weighted images are inherently noisy and low spatial resolution. Therefore, the deep learning super resolution can improve spatial resolution without changing conventional imaging parameters. So unfortunately, now this is not commercially available and work in progress sequences. So one accounting for the respiratory triggered MRCP, this is a very excellent image quality with higher spatial resolution. But the deep learning super resolution, by applying the deep learning super resolution, substantial improvement of spatial resolution can be achieved even for the respiratory triggered MRCP. So this is the same case of the MRCP images. This is reconstructed by the deep learning reconstruction, and this is reconstructed by the deep learning super resolution. So this is almost same image, higher image quality. But when we observe the enlarged image, intrahepatic bile duct is clearly visualized on the images with deep learning super resolution. So deep learning super resolution can be potentially applied for the dynamic contrast enhanced imaging. So they are the arterial phase image reconstructed with conventional reconstruction and deep learning super resolution. So as you can see, the improved image quality by denoising and upscaling resolution with has been achieved for the images with deep learning super resolution within the limited breath holding time of the 15 seconds. So they are the all dynamic phase images in the carboxylic acid enhanced MRI. So hepatocellular carcinoma is located in the segment 6 of the liver, showing the arterial phase hyper-enhancement followed by washout and heterogeneous hypointense in the hepatobiliary phase images. So when compared with the conventional imaging, deep learning super resolution is image can clearly delineate the tumor contour. So basically, hepatobiliary phase images are obtained with 3 or 4 millimeters rise thickness. And when applying the deep learning super resolution, 2 or 1 millimeters rise thickness when hepatobiliary phase images can be obtained. So this may contribute to improved diagnosis for the detection of small focal liver lesions. So also, hepatobiliary phase images using the higher flip angle with deep learning super resolution can obtain the Day3 images compared with the normal reconstruction image. So Day3 images demonstrate clearer continuity by using the deep learning super resolution. So we really expect focal liver lesions and bile duct anatomy for the liver surgery can be clearly visualized by using the deep learning super resolution. So finally, I'd like to show about the automatic lesion detection that we are working on. So we are now developing the AI-based diagnosis system of HCC in carboxylic acid enhanced MRI by using machine learning model. So this model may try to differentiate focal liver lesions from normal liver parenchyma without so much training data compared with the convolutional neural network model. So this AI model is constructed by the 3 steps. So firstly, liver contour is extracted based on the hepatobiliary phase images, and the segmentation is performed to divide into the small region of similar signal intensity, so-called superpixel. So after the liver extraction and the segmentation, future extraction is obtained from each MR sequence in each superpixel. So to evaluate this is a cancerous lesion or non-cancerous lesion. And finally, prediction is performed whether the lesion is HCC or not. So a total of 98 patients with 424 lesions are included in this trial. And the final diagnosis of the gold standards diagnosis of the focal lesion is as shown on the slide. So when they're accounting for the regarding the large regions, higher sensitivity has been achieved for this AI model. However, sub-centimeter region cannot be sometimes detected due to the poorer liver to tumor contrast or poorer image quality. So images with deep learning reconstruction or deep learning super resolution can increase the diagnostic performance for our AI model. So additionally, we are now collaborating with the Tokyo Institute of Technology to develop an explainable AI model for liver cancer diagnosis with providing the reason for the model prediction in domain-specific RILAS language. So explainable AI, XAI, is an AI system to help understanding and interpreting automatic diagnosis system. So unlike the usual AI algorithm, XAI can be potentially elucidated how AI models arrive at their decision or predictions. So our XAI model is comprised of 4 integral modules: feature extraction, RILAS feature selection and prediction, tumor classification, and domain-specific diagnosis. So this study comprised of gazoxylic acid-enhanced MRI from 94 patients and incorporates diagnostic reports containing 221 liver tumors with 89 malignant and 132 benign lesions. And this report contains diagnosis results with RILAS assessment by the expert abdominal radiologist. So unfortunately, this is confidential for the result. So I cannot show the results of our study, but the XAI will design the same diagnostic process to radiologists, potentially providing understandable reasons for the AI-based diagnosis. So in conclusion, deep learning reconstruction and deep learning super resolution can improve image quality, applying various sequences in hepatobiliary MR imaging. And AI-based automatic region detection and diagnosis systems in MRI are promising tools to assist clinicians in the management of hepatobiliary disease. Thank you for your attention.
Thank you very much, Dr. Software. Dr. Software teaches us the advancement of MR technique, especially about deep learning reconstruction. Are there any questions or comments from the floor? Okay, I have 3 questions.
Okay.
One is about the transient severe motion in EOB MRI. How is the merit about TSM decrease?
Maybe I don't think, because the motion artifact cannot be delineated to using the deep learning reconstruction.
Okay, thank you. And the second is about the quantitative value. You showed ADC value of deep learning reconstruction image. How the value is changed or not changed?
It's a very good and potential issue for the quantification with using the diffusion weighted imaging. So only the volunteer images we obtained are quite similar ADC values along the 3 types of the diffusion weighted sequence. But clinically, I'm not sure, but this is a problem for the quantification.
Yeah, thank you. And the last question is about automatic lesion detection. You show the result about hepatobiliary phase image of EOB MRI, and the lesion size more than 20 millimeter is about 100% detection rate.
Yes.
But below 10 millimeter is about 66%.
Yeah.
But I think the merit of hepatobiliary phase image is we can easily detect a small lesion.
Yeah.
So do you have any plan or some idea to improve the small lesion detection?
Thank you for your great question. So to detect the tiny lesion in the liver is using AI model is very challenging because partial averaging or motion artifact is prominent, especially on the periphery of the liver. So the small lesion, tiny sub-centimeter lesion cannot be detected using the sequences. And the misregistration among the several MR sequences is another problem. So I'm not sure how to address this issue, but more detailed image quality and using the thin slice image can, I really expect the improve the image diagnostic performance of the AI model.
Thank you. Do you have any?
So thank you very much for your excellent presentation. So before deep learning reconstruction, we have used compressed sensing reconstruction algorithm.
Yes.
Based on my experience with the CS reconstruction, we can speed up the acquisition quite significantly.
Yeah.
With the deep learning reconstruction, we can make image quality improvement from medium quality images to superior quality images. It's my experience. But if image is contaminated with some motion or significant artifacts, sometimes super resolution deep learning may stand out those artifacts more significantly. So ugly images may not get improved in terms of image quality with the deep learning reconstruction. So what's your opinion regarding that? I hope future deep learning reconstruction algorithms should focus on eliminating some artifacts rather than improving image quality by lowering noise and improving resolution a little bit using the zero interpolation reconstruction and super resolution or partial Fourier super resolution reconstruction.
Yeah. So yes, motion artifact is a major problem for the deep learning reconstruction. And to mitigate the artifact, we only reduce the acquisition time for to reduce the motion artifact. But as you mentioned, I agree with you about the deep learning program includes the motion artifact and to eliminate this artifact.
Are there any questions or comments?
Okay. Okay, thank you, Dr. Sobue.
Thank you.
And the next speaker is Dr. Xiaoyan Xu from China. The title is Advances in Hepatobiliary Imaging. Please start your lecture.
Okay. Thank you for the session chairman and ladies and gentlemen. My topic is about focus on in the communication of 3D single model fusion image in precise ablation entire process. I'm from Guangzhou, Sun Yat-sen University. As we know, the ablation is the first-line treatment for the HCC less than 3 cm, but the local tumor progression and is still high, and the 5-year survival is not good enough. The insufficient safety margin, I think, is the main cause. So where is the correct safety margin, and how to get the sufficient ablation and to assessment of the safety margin? It maybe is the topic about for the interventional doctors. As we usually, for a 2-centimeter tumor, we puncture maybe 2 needles and we can got mono-3C ablation. We think it's okay. But actually, in the real situation, maybe situation A or B or C. So it's how to get the safety margin precisely, and the quantitatively is very important. So we want to prove the 3D is feasible and vulnerable in the ablation, and from the development of grossly and to validation in the vivo, and then we have a clinical validation. And we set it the fusion system, use the ultrasound and the navigation system and the evaluation system. And we can get the 3D image to get the tumor segmentation and to plan, and then to guidance, and then we can use the 3D fusion to monitor the ablation and then to assessment the ablation effects. So we can get the quantify the safety margin, and then we can use the fusion image to re-guidance for the supplementary therapy. And if you use the ultrasound, it's very simple and have a good cost effect and no radiation, and it's faster. The process is firstly, we pre-ablation, we take 3D contrast ultrasound, of course, 3D CT, and then we plan and guidance, and then ablation at the monitor. And after ablation, we take the 3D again, and we fusion the 3D and the 3D CT to evaluate the safety margin. And this is our process. Here is in the real-time ultrasound, we take the 3D data by the free hand, and then the system will automatically segment the tumor and 5 mm or 1 mm ablative safety margin, and then the needle was placement was through the simulative ablation room, and the estimated coverage rate was automatically calculated by your needles and your power. And then by the real ultrasound, we can use, you can in place the needles according to the plan in the 3D fusion image, and then the puncture path and the depth was shown in the red line, and the plan ablation room is also was shown in the here. And intraoperative, we can monitor and assess the coverage of the ablation room was conducted through the contrast ultrasound and the 3D fusion image. This is our cases for the tumor, 3D data, and to segment the tumor and the safety margin, and we can simulating needle plans and the coverage of the tumor ablation area, and then we can take the ablation pump, and after that we can assessment the efficacy. Here is our real situation is before and during ablation, and here is the case, another case. So first the contrast ultrasound, and then we segmented the tumor and the safety margin, and then we have a plan by the simulation and puncture, and then we, according to the simulation plan, and we puncture the tumor, and then we have a ablation, and then we can evaluation. So the by our data and for plan and the guidance, the technique successful is 100%, and only one patient with supplemental ablation, and the no major complication. The minor complications is observed in 8 patients, and after 1 month ablation, the CR character is 100%. About the assessment, we used the mid-ray 3D ultrasound fusion and the contrast agency solo view. It's before ablation, and we segmented the tumor, and after ablation, we segmented the ablation area, and then we fusioned the two image, and so we can know how is the safety margin, and. By use in the assessment, we use the CT fusion IQQA level as a standard to compare with our technique. So we can divide the safety margin in ICR is no safety margin, or CR is larger than 5 millimeter, or safety margin is smaller than 5 millimeter. So here is the case, and then we compare the CT and compare with the ultrasound. You can see here is have no enough safety margin, and the patients have recurrence in the several months. So we found, first we compared safety margin in 2D and the 3D fusion image. We can find in total 97 patients, we have 96 patients with the 2D CUS is judgment as a CR, but by the 3D contrast fusion, it's only 16 patients, so it's quite different in 2 groups. And we can find the results is very similar in 3D fusion and 3D CECT. So it means the 3D contrast fusion is very important for the safety margin diagnosis. For this case, we can see the tumor is here, and the bigger area for after ablation, with judgment, the diagnosis of the patients is complete application. But by the 3D contrast fusion, we can know in this area the safety margin is less than 5 millimeter, and in the 3D CT, we have find the same situation. Just in this area, the patients have local recurrence for several months. The second, we found the evaluation effective of the safety margin by different methods. It means 3D contrast ultrasound is more sensitivity and specificity and accuracy than the 2D CUS. And also we can find the contrast ultrasound and the contrast CT fusion have a high consistency in evaluation the safety margin. And the fourth is the safety margin can predict the local tumor progression. In our data, we can find the local tumor progression is very high relative with the safety margin and size. And in our data for these patients, we can see here have no enough safety margin, and the patients have recurrence after 4 months after ablation here. So if the patient's safety margin is less than 5 millimeter, maybe the local tumor progression rate is high. And here is another case. It's not enough here in CT and in contrast ultrasound, and then recurrent in 6 months. In conclusion, the normal modality 3D fusion can lead to the precise segmental plan guidance and monitor during the ablation. and it's faster and precise quantitatively for assessment of the tumor ablation safety margin, and it's also helpful for guidance in the supplemental therapy, and it's helpful to improve the ablation efficacy. Thank you very much.
Thank you very much, Dr. Shi. Dr. Shi showed us the advancement of ultrasound, especially about the 3D US fusion imaging for RF ablation safety margin imaging. Are there any question or comment from the floor?
So I have one question for you. In clinical practice, we time to time use artificial ascites in order to avoid the side effect, unnecessary thermal injury to adjacent structures. When we use that, the liver deforms compared to what originally was. So based on your experience, still the 2D US and 3D CUS fusion is valid in such kind of a setting, or should we do pre-RFA CUS after installation of artificial ascites and then do the fusion?
Yeah, it's a very good question. It's for the patients use the artificial ascites, and sometimes it's difficult to fusion before and after. So usually we may be to have the artificial ascites first, and then take the 3D data, and then we ablation, and then to fusion the before and after image. But sometimes the ascites is become smaller, few and few.
Yeah.
So we must to perfusion some more liquid to the abdomen. Thank you. Yeah.
And another issue is you have to use the CUS 2 times in order to evaluate the first fusion and then monitoring the therapeutic effect.
Yeah, if the tumor is very clear for the margin, we just use the 2D data. It's okay. If the 2D is not clear, so we use the contrast ultrasound for the margin of tumor. So, yeah, thank you.
Any other comments or questions? I think your approach is quite important in China because many ultrasound departments prefer not to upload the CUS images to the PACS, and also you have a limitation in having the contrast in CT or MR for guiding the procedures. So maybe single modality fusion might work well in China.
Yeah, I think so. Actually, I take the multimodal fusion before, but in the multimodal fusion, it's maybe the image become very beautiful, but actually in the ultrasound, it may be some difficulty. So I think in some situation, and that ultrasound imaging is very useful. Thank you.
Okay, thank you very much, Dr. Shi.
Thank you.
Okay, the last speaker in this session is Dr. Yasunori Minami from Japan. The title of the presentation is Challenging Precise Ablation, US Overlay Fusion Guidance. Please start.
Thank you, Chairman. Good afternoon, everyone. My name is Yasunori Minami of Kindai University, Osaka, Japan. My topic is the challenge precise ablation, USS overlay fusion guidance. So as you know, the ablation therapy is very useful and effective for early stage HCC. However, ablation therapy have a limitation of relatively higher rate of local recurrence. So as Professor Shimin Lee reported in his paper, the bigger HCC, the more frequent in local recurrence after ablations. So as you can see, HCC and ablative merging is not clear on B-mode US immediately after ablations. So this is a clinical issue on ablation therapy. We usually depend on the ultrasound image for the decision of the endpoint of ablation. However, it is sometimes difficult to assess ablative merging on ultrasounds. It could induce sufficient ablative merging assessment. It could be a risk of local recurrence. If SCC and ablative merging could be specified on ultrasound during ablation, it is expected that the rate of safety imaging and local recurrence would be improved. So we have reported the usefulness of guidance of USS fusion imaging and USS ovary fusions. USS fusion imaging can show synchronous two ultrasound images before and after RFL side by side. This image can be overlaid like this. You can see the ablative hyperechoic zone entirely including green colorized HCC. That is, ablative merging can be shown as the difference between the ablative hyperechoic zone and the green colorized area. So ablative merging can be assessed three-dimensionally by swing scanning like this. You can see the CT image of this, in this case, post-treatment CT shows the successful ablation with enough margins. Another case, you can see the 2.2 centimeter SCC in segment 3. We treated it with overlapping ablations. It looks good ablation side by side by USS fusion imaging. And as you can see, the ablative hyperechoic zone entirely including green colorized HCC. That means good ablation with enough margins. As you can see, the post-treatment CT shows the low density area spread to the surrounding the vessel. That means the good ablation with safety margins. So this is the assessment of tumor ablation between the CCT versus USS ovary fusions. We could reach the rate of safety margin achievement to 86.8%, and the accuracy of early assessment of tumor ablation with USS ovary fusion was 92.6%. You can see the local recurrence curves between the USS ovary fusion guidance and the conventional techniques. The rate of local recurrence was significantly lower in USS fusion guidance group. So with the use of USS ovary fusion guidance, ablative merging could be visualized. Insufficient merging now area could be pointed out during the ablation procedures. So therefore, USS ovary fusion guidance could be improved the rate of success safety merging achievement, and it is useful for early assessment of ablations. So now you may have simple questions. Is an ablative hyperechoic zone equal to necrotic areas? Previous studies compared between ultrasound images and pathological findings. One paper said ultrasound overestimated ablation zone. However, another said ultrasound underestimated it. However, the other said the ultrasound estimation could depend on the ablation time after ablation. However, this article have a same limitation. They could not compare the same cross sections. So, clinical question: can the ablative hyperechoic zone be regarded as a necrotic region after RFAs? Our aim of study was to compare the ablative hyperechoic zone with the non-enhanced area on CUS or CCT on the same cross-section using CT fusion imaging. For the one case I present here, that you can see the 2.8 centimeter SCC in segment 7 touching the IVC and the right hepatic vein. You can see the ablation zone image comparing the same cross-sectional image. Left side is B-mode image shows the ablative hyperechoic zone measuring 30 millimeter by 34 millimeters. Middle shows low intensity area on contrast enhanced ultrasound measuring 30 millimeter by 34 millimeters. Right is the, you can see the low density area on dynamic CT measuring 30 by 35 millimeters. You can see the scatter plot of ablation zone between B-mode US versus CUS with the same cross-sectional imaging. So R value for long and short dimension was 0.98 and 0.7 respectively. So these results shows the highly positive correlation of ablation size between the B-mode US and CUS. And you can see that this is the scatter plot of ablation zone between the B-mode US versus CCTs. The R value for long dimension and short dimension was 0.93 and 0.93 respectively. So these results shows also highly positive correlation ablation size between the B-mode US and the CCT. This is an image of ablation on ultrasound and the pathological specimen of pigs. We consider that ablative hyperechoic zone is expand to outer congestion layer. According to our results, we concluded that ablative hyperechoic zone on B-mode ultrasound is almost equal to a vascular area. So it is important, it is appropriate to monitor early response of ablation therapy by ablative hyperechoic zone on B-mode US. And USS ovary fusion guidance can accelerate the development of precise ablations. And one more slide. If you have time and you have chance, please welcome to Osaka. Many attractions are waiting for you. Thank you. Thank you for your attention.
Thank you very much, Dr. Minami. Dr. Minami's lecture is also about ultrasound, and he is especially talk about the visualization of ablation margin during RFA. Are there any question or comment about his lecture? Do you have
So I have one question for you. So in order to make the tumor segmentation on ultrasound, the tumor visibility should be very good. If
Yes, yes.
on B mode image, if tumor margin is not well delineated, probably accuracy of segmentation may not be accurate. So in my country, we have many hepatitis B related liver cirrhosis patients, and then the tumor conspicuity is not so great because there are so many regenerative nodules
Yeah,
around
I
the
agree with
tumor.
you.
So maybe that's the reason why Dr. Xie used CUS instead of B mode ultrasound. Maybe in Japan, you have more hepatitis C related liver cirrhosis, and then the tumor in general stands out well in the background of micronodular liver cirrhosis.
Yes.
Is it my explanation is correct?
Correct.
Okay.
Correct. If you get a good image on B mode, yes, it is good, the B mode guidance. And we check the ablative area using the USS ovary fusion. However, the SCC with poor conspicuities, we use the CUS of sonazoid.
Yes. Yes, Dr. Xie, please.
Professor Minami, I have a question for you. Just by your lecture, I know the gas shape is no enhancement area. It's similar.
Similar.
No, it's no enhancement area after ablation.
After ablation.
Yeah. But sometimes I didn't pay attention about the gas shape before. But sometimes the gas shape is irregular. In the irregular round, or what's the meaning, and what will be happening in that situation?
Yeah, that's a very nice question. So, as you know, the ablative hyperechoic zone will disappear. What is a good timing? I think that your question. I think that about 5 minutes after ablation. 5 minutes to 10 minutes. It's a golden time, I think.
Okay. It's timing is when important.
Yes.
Thank you. Thank you.
So actually the hypoechoic bubble deposition area is changing over time, as you mentioned.
Yes.
So if you want to use a B mode imaging to judge the ablation zone, 5 to 10 minutes would be ideal time. But if we want to use a CUS, maybe after 10 minutes is better because we want to have a clear background.
Yes.
Yeah. So maybe depending on the purpose of examination, but timing would be different. And I am wondering, as your peripheral bubble hyperechoic zone at 5 to 10 minutes after ablation, is correspond to congestion area on pathology or specimen. So that area is regarded as intermediate viability zone. It can undergo necrosis in the future, and some part could be survived because it's a partial thermal injury zone. So maybe the hyperechoic zone should be larger than the ideal safety margin. If we consider that as an intermediate viability zone.
Before started our studies, checking the hyperechoic zone and the same cross image, I have the same idea. However, I check the size, almost the same.
Okay. So that is a vascular area, indeed. Okay. Are there any questions or comments? So do you use a GE system?
Yes.
And she use, Dr. Xie use Mindray system? Yeah.
And
Mindray.
Canon. Yeah,
And
Mindray
Canon.
and Canon. Yeah.
Okay, so you are using the same ultrasound probe, the 2D probe, for making 3D ultrasound volumetric data acquisition. It's a manual acquisition.
Manual.
Okay.
Same,
The
the same.
same, principle-wise the same. Okay.
Please close.
So thank you very much for all three speakers who made excellent presentation. And also, I'd like to close the session with the big thanks to our audience who are in this room. Hopefully, enjoy the rest of the meeting and please enjoy the Kyoto. Thank you very much.
Thank you very much, speakers and moderators. Now we will have a coffee break. The next session will start at 5:10 p.m.